When your stomach won't stop, understanding Gastrinoma and Zollinger-Ellison syndrome. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon, and if you or someone you care about has been dealing with relentless heartburn, ulcers that just won't heal, or persistent diarrhea that seems to defy standard treatment, you're in the right place. I know when you've tried every medication your doctor's prescribed and symptoms keep coming back, it's beyond frustrating. It's frightening. A gastrinoma is a rare functioning neuroendocrine tumor. That's a growth that secretes hormones, that produces excessive amounts of a hormone called gastrin. Gastrin normally tells your stomach to produce acid for digestion, but when a gastrinoma is present, it's like having the accelerator stuck to the floor. Your stomach produces massive, uncontrolled amounts of acid. This condition, called Zollinger-Ellison syndrome, affects your digestive system profoundly. Why does this matter to you personally? Because standard ulcer treatments won't work properly when there is this relentless acid production happening, and understanding this can literally change your treatment path from frustration to relief. The most important thing to understand is that Zollinger-Ellison syndrome often masquerades as common digestive problems. According to research examining 261 patients with this condition, the most prominent symptom is actually diarrhea, not just ulcers as standard teaching might suggest. What makes this different? You're dealing with peptic ulcers that are multiple, recurrent, or in unusual locations. We're talking about ulcers that don't have the typical causes. No Helicobacter pylori infection, no NSAIDs like ibuprofen, no Crohn's disease. These are ulcers that keep coming back despite appropriate treatment, or they appear in atypical locations in your digestive tract. You might experience severe gastroesophageal reflux disease, GERD, that responds temporarily to proton pump inhibitors or PPIs, but symptoms return aggressively. If you're supporting someone through this, you might notice they're taking increasingly high doses of acid-suppressing medications just to function day to day, yet they still struggle with pain or diarrhea that disrupts their life. Here's something that might surprise you. Diagnosis has actually become more difficult in recent years, not easier. Why? Because doctors now prescribe PPIs, medications like omeprazole or lansoprazole, very early for any digestive symptoms. While these medications are excellent for typical ulcers, they mask the signs of Zollinger-Ellison syndrome and interfere with diagnostic testing. The classic diagnosis requires 3 specific findings working together. First, you need a fasting serum gastrin level that's elevated at least 10 times above the normal upper limit. Second, your gastric fluid pH needs to be 2 or less. That's extremely acidic. Third, you need the characteristic symptoms. A normal gastrin level might be up to 100 picograms per milliliter. But here's where contemporary practice has evolved. Up to 2/3 of gastrinoma patients have been found to have fasting gastrin values less than 10-fold normal in recent studies. If you're on PPIs, which most patients with ulcer symptoms are, your gastrin levels will be artificially elevated, making interpretation difficult. About 20 to 30% of gastrinomas occur as part of a hereditary condition called multiple endocrine neoplasia type 1, or MEN1 syndrome. This is critical information if you have a family history of endocrine tumors. Research demonstrates that Zollinger-Ellison syndrome can actually be the first manifestation of MEN1. What does this mean for you? If you're diagnosed with a gastrinoma, your doctor should evaluate you for other endocrine tumors, particularly in your parathyroid glands and pituitary. If you have MEN1, first-line family members have a 50% probability of being carriers. That's your children, siblings, and parents. Patients with MEN1-associated gastrinomas face particular challenges. Studies show they have an increased risk of severe esophageal disease, including strictures, areas where the esophagus narrows, and Barrett's esophagus, which is a premalignant condition. If this applies to you or someone you're caring for, regular surveillance becomes crucial, not optional. Almost all cases of gastrinoma can be clinically controlled with high-dose PPIs. Research on long-term treatment with these medications shows they effectively control the acid hypersecretion. We are typically talking about doses like 60 to 80 milligrams daily of omeprazole, sometimes divided into multiple doses. That is substantially higher than the standard 20 milligram dose used for typical heartburn. In acute settings where you can't take oral medications, say you're hospitalized, intravenous formulations work effectively. Studies show that 80 milligrams of pantoprazole, given by 15-minute infusion every 8 hours, controlled gastric acid hypersecretion in all Zollinger-Ellison syndrome patients studied both acutely and up to 7 days. For sporadic gastrinomas, those not associated with MEN1, surgical resection represents the gold standard treatment when the tumor can be located preoperatively. Research demonstrates that surgery increases survival in patients with gastrinoma. Even patients with negative preoperative imaging benefit from surgical exploration with curative intent. The type of surgery depends on tumor location. Most gastrinomas occur in what's called the gastrinoma triangle, an area in the duodenum and pancreas. Surgery typically involves careful exploration, often requiring duodenotomy, opening the duodenum, and systematic lymph node removal, which improves outcomes and reduces recurrence. Here's something hopeful. With appropriate treatment, quality of life can be preserved. A prospective study specifically evaluating quality of life in Zollinger-Ellison syndrome patients found that modern management significantly improves daily function. Long-term survival data show that, with proper control of acid secretion and tumor management, many patients live for years with good quality of life. Studies examining clinical course, prognostic factors, and survival in patients with long-standing Zollinger-Ellison syndrome demonstrate that survival depends on several factors: whether the tumor has spread to lymph nodes or liver, the tumor's growth characteristics, and how well symptoms are controlled. If you already have metastatic disease, meaning the tumor has spread, this doesn't mean giving up hope. Multiple treatment modalities exist beyond surgery, including somatostatin analogs, which can control both hormone secretion and tumor growth, and peptide receptor radionuclide therapy, PRRT, which delivers targeted radiation to tumor cells. Studies show clinical response rates of 16% with certain combinations. If you have peptic ulcer disease without H. pylori infection, aren't taking NSAIDs, and don't have Crohn's disease, especially if ulcers are multiple, recurrent, or refractory to treatment, ask specifically about testing for Zollinger-Ellison syndrome. The exact question to ask: should we check my fasting serum gastrin level and gastric pH to rule out gastrinoma? If you're already on PPIs and experiencing ongoing symptoms, discuss the diagnostic challenge this creates. Your doctor may need to follow published protocols for temporarily withdrawing PPIs under careful supervision to get accurate testing. This requires caution because PPI withdrawal can cause rebound acid hypersecretion, potentially leading to ulcers, bleeding, or perforation. If you have diarrhea that improves with PPIs, along with ulcer symptoms or severe GERD, mention this combination specifically. Research shows diarrhea responsive to proton pump inhibitors is a key diagnostic clue that often gets overlooked. You should pursue evaluation at a center experienced with neuroendocrine tumors if standard ulcer treatment fails after 8 to 12 weeks, if you have a family history of MEN1 syndrome or endocrine tumors, or if imaging studies identify a pancreatic or duodenal mass along with your ulcer symptoms. If diagnosed with gastrinoma, ask about comprehensive imaging, including endoscopic ultrasound, which can detect small tumors, CT or MRI scanning, and somatostatin receptor imaging using specialized PET scans. These tests help determine if you're a surgical candidate and whether the tumor has spread. If you start high-dose PPI therapy, you should see symptom improvement within days to weeks. That's rapid relief from the relentless acid production. However, continue your medication exactly as prescribed even after symptoms improve, because the underlying tumor is still producing gastrin. After surgical resection, it is advised to continue PPI therapy for at least 3 to 6 months, because many patients continue to hypersecrete acid for some time as their parietal cell mass, the acid-producing cells, gradually returns to normal. Recovery from surgery typically takes several weeks, but this varies based on the specific procedure performed. Gastrinoma causing Zollinger-Ellison syndrome should be considered when ulcers don't respond to standard treatment, especially with severe GERD or PPI-responsive diarrhea. Your next step: discuss fasting gastrin testing and gastric pH measurement with your doctor if you have refractory symptoms. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. These include the European Neuroendocrine Tumor Society 2023 guidance papers, published research from the National Institutes of Health on gastrin testing and Zollinger-Ellison syndrome diagnosis, and clinical practice guidelines for neuroendocrine tumors. All links are available in the description below. Thank you for watching.